Dr. Sangeet Aggarwal. Dr. Sangeet Aggarwal is a consultant and associate professor in head and neck surgery and oncology department of ENT at Sir Gangaram Hospital. And he specializes, as his designation is, the head and neck cancer surgery. And he has expertise in advanced oncologic and laser surgical procedures. And he has fellowship training in head and neck oncology from leading national and international institutes. And he has an extensive experience in managing complex surgeries. This we have also witnessed, and we are very fortunate that he's part of our institute. So over to you, Dr. Sangeet.
Hello, I am Dr. Sangeet Aggarwal. Thank you, Dr. Mamta. On the occasion of World Oncology Day, I will show some pre-malignant lesions because uh, pre-malignancy is a such type of condition. If we catch up in the pre-malignancy, then we can prevent the oral cancers to be happen in the future. So we have a lot of patients which have a pre-malignant conditions, and if we do proper treatment of the pre-malignant conditions, then we can stop the to be having a malignancy. So my next slide. Mm, hmm. So pre-malignant conditions can be defined as a benign lesions with morphologically altered clinical or histopathological tissue which has a greater than normal risk of containing microfocus. So basically, what are the pre-cancerous conditions? So initially they are benign lesions, but if they are not treated well or not treated properly, or if they can convert into a malignancy without any without any pre I mean without any habitual conditions. So these are the some conditions in which we have a some lesions, they can convert into cancers. So if some my next slide please. So it was recommended in WHO workshop of 2005 to abandon the distinctions between precancerous lesions and precancerous conditions, to use instead of term potentially malignant disorders, incorporating both the terminologies. Okay, so next slide. Okay, so we can start from here. So the etiology of pre-malignant conditions, it may be tobacco in the any form, so in the chewing form or a smoking form. So it is a most, it's the single most major extrinsic cause for any pre-malignant condition. Number two is alcohol, and number three is a virus infection, which may include human papillomaviruses, Epstein-Barr viruses, HBV, HIV, and HSV. Then some bacterial infections like Treponema pallidum, and some fungal infections like Candidiasis. So this is a chronological order from high to low risk. So tobacco is the most common, most highest risk factor for any pre-malignant conditions. Then alcohol, virus, then bacterial, then functional. Then fungal infection. Next slide. In some cases, ultraviolet radiation, some chronic. Yes. So the number 7 point nowadays, what I am uh, feeling in my OPD, that some patients without any tobacco history, without any risk history, there are some chronic inflammation or irritation by a sharp teeth. I found many patients, especially female patients, without any risk factor. So they have a tongue cancers. So irritation from a sharp teeth, and if there is a ulcer on the lateral border of tongue, which is I will show in my slides. There are some pictures of that. So if there is a ulcer which is non-healing and there is a irritation from a sharp tooth, it may be a malignant condition, or it may be a pre-malignant condition. So these type of mm, ulcers should be biopsied. There are some intrinsic factors also. There may be genetic immunosuppression. Yes, immunosuppression is also a very big factor nowadays. I have some a series of patients which are organ transplant patients, especially kidney transplant patients, which are immunosuppressed patients. They have a more tendency to develop the malignancy without any um, tobacco or alcohol or smoking habitual. Then there is a malnutrition also, which is a very low risk factor. My next slide. So this is a classification in which there are most common condition is a oral leukoplakia, then erythroplakia, then oral submucosal fibrosis, oral lichen planus, oral lupus erythematosus, palatal lesions in reverse smokers, actinic cheilitis, disc keratosis congenita, and epidermolysis bullosa. So, first first is leukoplakia. So it is a wide plaque of questionable risk, having excluded uh, other other known diseases or disorders that carry no increased risk of cancer. Such type of conditions, they are common conditions, and found one or two patients every day in our outdoor patient department. So what we now leukopenia and erythroleukopenias. So these are the two potential pre-malignant conditions. And yes, another one is nowadays lichen planus. What I found is a lichen planus. I have at least 4 5 patients in a recent 4 5 months. Those patients have a lichen planus, and believe me, they develop into malignancy. So these are the very bad conditions. So these conditions should be treated as soon as. So basically, this is a pathology of these pre-malignant conditions. There have a increased creatine production, change in epithelial thickness, and disordered epithelial maturation. Next slide. So, as previously I said, so these may be associated with smoking, smokeless tobacco, alcohol, and betel nut. HPV associated a very small percentage. Next slide. So, if we see by a clinical features of these conditions, so there are small focal white plaques, generally asymptomatic. Tongue, gingiva, buccal mucosa, and palatal mucosa are most commonly affected sites. And what is a alert sign for these? So this is a very important point, because whenever there is a leukoplakia or any pre-malignant condition like lichen planus, and it is limited to a one subsite of a oral cavity, or maybe two subsites of oral cavity. Like, number one is, if there is a leukoplakia or erythroleukoplakia which is limited to lateral border of tongue, number one. Number two, ventrolateral tongue. Number three is floor of mouth, and number four is retromolar trigone. So these are the four subsites in the oral cavity. If there is a isolated leukoplakia, erythroplakia, or oral lichen planus, we should address them as soon as possible by a best possible treatment, which I will discuss later. So my next slide. So these are the some types of leukoplakia. So these include homogeneous leukoplakia, non-homogeneous leukoplakia. So basically, there is a varicose leukoplakia. then nodular leukoplakia, erythroleukoplakia. So these are the some types of leukoplakia, and according to these types, there is a high risk of cancer development. Like in a varicose leukoplakia, there is some more high risk than, and highest risk is in the erythroleukoplakia. Next slide. So these are some pictures like isolated pre-malignant conditions, leukoplegia. So this is middle picture is a isolated leukoplegia in the lateral border of tongue. And these type of conditions are very risky conditions. So if it is not a malignancy today, but it can be a malignancy in a future. So they should address as soon as possible by a small surgery today. But if it becomes a malignancy, then it will be a big surgery with very bad prognosis. Next slide. These are some other pictures. So the isolated pre-malignant conditions, and they should address by a small surgery, small surgical excision. But one thing is there ki surgery should not done upfront. We should take a biopsy first. If in the biopsy there is a leukoplakia or a pre-malignant condition, then we should excise it as with some 2 to 3 millimeter margins. Next slide. So this is a risk profiling. Lesion size is more than 200 millimeter square. Homogeneous site excludes tongue and floor. So this is a low risk. So I said whenever there is a lateral border of tongue or floor of mouth or RMT and heterogeneous and more than age is more than 40 years, family history of cancer, non-habit associated. Yes. So the last point is non-habit associated. If there is a isolated pre-malignant condition without any habit, this should address as soon as possible because the chances of uh, changing into malignancy is very high. So next slide. So this is management. So first of all, what we advise to the patient is to quit the if he or she has some abuse like tobacco abuse, betel chewing, alcohol, smoking, etc., etc. Uh, if there is no habit, then there is no, then it should upfront excision of the lesion. Then clinical examination is repeated. If there is a habit, patient has quit the habit and the lesion is not very suspicious, so we can put the patient on a observation 2 3 weeks or at least or after a month we should examine the patient. But if there is any risk factor like if the lesion is on the lateral border of tongue or the floor of mouth, then it should address in a first instance only. Next slide. So this is a basically a conservative management, but not very promising results of this management. But yes, it is written in the books or in the literature with very few, very small results, very small good results. So it's a vitamins, retinoids, carotenoids, bleomycin, protease inhibitor, anti-inflammatory drugs, green tea, etc., etc. But this is a conservative treatment in those patients which have a pre-malignant condition on those comes into a low risk group. So next slide. So surgical treatment is the mainstay of the treatment. So I have a patients, those maltreated by some surgeons, some other peoples, and making some injections or ointments and drugs etc., and they become the malignancy. So This should not be done, and the surgical treatment should be there by a conventional surgery, or it may be a laser surgery, or it may be any other type of surgery by any other instrument. So it should be excised properly with at least 2-3 millimeter margins with proper reconstructions. My next slide. So it is a proliferative varicose leukoplakia. Okay, so next slide. So these are the type of leukoplakia. So it has a high malignant potential. It mostly in the older female. It's on the lower gingiva. Varicose carcinoma or squamous cell carcinoma may present at the primary examination. So the proliferative varicose leukoplakia can convert into varicose carcinoma or squamous cell carcinoma. So it should be excised as soon as possible. Next slide. So frequently we encountered such type of conditions. So this is looking, this is a varicoid type of leukoplakia, and if it stays like it can get convert into malignancy. So these type of conditions should be excised as early as possible with some skin grafting or some good reconstruction. Next slide. So this is a small flow chart in which what I have said, I have explained leukoplakia, then we should do biopsy first. If it is non-dysplastic, then we can observe it. If it is dysplastic, so we should excise it because dysplasia is a pre-malignant condition, or and we can say it is a carcinoma in situ. Then uh, So, poorly demarcated like frictional, then rebiopsy, well demarcated, then so it's a long flow chart. So the whole idea is if the patient is a high risk patient is high risk, then we should excise it. That's it. Next slide. Nowadays, oral lichen planus is a big headache for all of us because it has no good treatment. Even we don't have treatment because oral lichen planus is a such type of condition which is very nowadays. It's a common condition which involves buccal mucosa, tongue, skin, nails, scalp. And if it is localized to some region, we can excise it, but generally it is a general condition. So it's a big headache, and we don't have any treatment except for surgery if it is limited to some region. Next slide. So it's a basically immunological conditions. Uh, Next slide. So these type of conditions have a lacy pattern with itchy purple spots on the wrist, leg, and trunk. About 30% of patients have a both oral and cutaneous lesions. So oral lesions are frequently asymptomatic and seen as an incidental finding on oral examination. Lesions tend to be intermittent recurrent and symptomatically confused with recurrent aphthous ulcers. So lichen planus have some uh, lacy type of pattern, and it should be biopsied first. And if it is lichen planus and it is limited to a small region or small subset in the oral cavity, they should be excised. And if it is generalized, then we can't do such a big surgery for a lichen planus, and they should be treated by some medicines and kept patient on vigilant observation. Next slide. So this is so basically the intensity of symptoms vary with, but patients typically report sensitivity to spicy or acidic foods, painful oral mucosa, mucosal surfaces, roughness and tightness of the mucosa. Typically bilateral distribution. So it's a mainly it's a bilateral distribution. So we can't excise both the cheeks or both the buccal mucosa, tongue and gingiva because it is a generalized condition. Next slide. Next slide. So it's a mostly autoimmune condition. So such type of conditions which are autoimmune, then we can't do much for the patient. Next slide. Next. So this is a typical picture of oral lichen planus. So it's a big lesion, which is a white lacy lesion. So what we do, we first do a biopsy and prove it. Then we with a team of dermatologist and immunologist, and we treat this condition. If it is on the suspicious aspect, if it gets convert into if we find that it may convert into malignancy by our examination, then we should excise it and we do a proper patient. Next. These are some other lesions also, but they are rare lesions. Next. This is also a leukoplakia condition. This is next. These are some other conditions. Next. 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 So, as I said, there is no cure for local oral lichen planus. Patient should be kept on vigilant observation, and if it is limited to some small region, then they should be excised. Next. Next. Some people uses oral this steroids also, but no promising results. Next is oral submucosal fibrosis, which is very common in India, and it is associated with tobacco chewing or betel nut. So it's a fibroelastic changes of the lamina propria with epithelial atrophy, leading to stiffness of the oral mucosa. It's a very bad condition and pre-malignant condition, and it should be, but unfortunately it has no any treatment at all. So what is the treatment? Next. So this is a betel nut chewing. Next. So this chart shows this is a oral mucosa with the betel quid habit, constant irritation. It gets converted to chronic inflammation. Then activated T cell macrophages at the sites. Then cytokines increase. Then it gets converted to oral submucosal fibrosis of the oral mucosal fibrosis. Next. 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 So it can be mostly in the middle age people from 30-40 years, but it may be in the uh, children also, and up to the 80 years. And in India, it's most common in male because mostly betel nut chewers are male, but maybe in the female also. Next. So burning vesicles, increase, decrease salivation, all sensation, pigmentation, ulcerations is the earliest stage, early stage. Next. Oh, this is some pictures of oral submucosal fibrosis. Next. Next. These are some pictures. This shows the mouth opening, and this is very bad condition because this the fibrosis is a irreversible process, and even after stopping the betel quid chewing, it almost a irreversible process. So it's a very bad condition and pre-malignant condition. And unfortunately, the treatment is very um, uh, uh, the treatment is a very big surgery for the oral submucosal fibrosis. So what we advise to the patient is to quit the uh, predisposing factor, predisposing addiction, and then we put the patient on a vigilant observation to see is there any development of the cancer in the oral cancer or not. Next. These are some other conditions. Next. When it converts into severe stage, so difficulty in eating, nasal twang, hoarseness of voice, deafness, hypertrophic masseter muscles. So these are it is in this very severe stage. Next. So you can see the severe stage, mouth opening is almost totally gone and patient suffers a lot. Next. These are some other conditions. Next. So you can see the management is eliminate the risk factors, tobacco, recascization, alcohol reduction. Uh, Best treatment is surgical management, but surgery is a big surgery and lot of patients not afford this surgery. This is a free flap surgery. Proper reconstruction should be there. We excise whole of the mucosa from the mouth and both side of mouth, and patient needs a free flap, means proper reconstruction surgery, which is a 7 to 8 hour surgery. And for non-cancerous condition, which is not a cancer, just a oral submucosal fibrosis, we generally don't advise this surgery until unless the patient has a no mouth opening. So otherwise there is no medical management. This is a topical corticosteroids, and this is a just basically this is not a treatment for, if we give topical corticosteroids, this is not a proven treatment actually. Next slide. These are some other um, hypothetical treatments, just a pentoxifylline or something like that. Next. Antioxidants, lycopene, curcumin, multivitamins. These are some supportive treatments only. Next. We can do ultrasound therapy, which is there is a physiotherapy or a mouth opening exercises, but these are some only a support. Next. Surgical therapy is there, but it's as I said, it's a big surgery, some mucosal resection and replacement with partial thickness skin or mucosal grafts, and maybe a free flap surgery, bilateral temporal myotomy, oral stents. So these are the big surgeries. Next. Thank you. Okay, thank you. Any question?
Thank you, Dr. Sangeet, for taking us. Sorry for my hoarse voice today.